Hello everyone and welcome to this MHA Schools Masterclass. It's Pedro Gondim here, Mental Health Academy CEO and your host for today. And joining me for the Masterclass is Dr. Anastasia Ronis. Anastasia, how are you today?
Hello, I'm good, thanks. Thanks for having me.
It's always a pleasure. It's not our first rodeo together, so and you know rodeos, so
That I do.
So it's great to have you on board, and very important topic today for teachers, to support teachers out there who want to support children who have intellectual disabilities, are at many ways at a disadvantage and really need that tailored, effective support to help them thrive in the school environment, but also beyond. Looking forward to this, but before we start the juicy stuff, I want to take a moment to introduce Anastasia. For those of you that don't know her work, and she has done a presentation for MHA Schools before, so you may have watched that, but if you haven't, take a moment to learn more. So Dr. Anastasia Ronis is a clinical psychologist working across both clinical practice and academia. She's a lecturer and researcher at the University of Technology, Sydney, and conducts research in the areas of addictions, intellectual disabilities, and rural mental health. She's also the founder of the Australian Institute of Human Wellness, an organization dedicated to meeting the growing need for innovation in supporting mental health and well-being. In 2024, Anastasia published the book, The Dopamine Brain, with Penguin Books Australia and New Zealand. It has since been sold internationally, and if you've been in an airport, at least in Australia in the last few months, you most likely have seen her book on the shelves, which makes her very happy, I know that. Anastasia has also worked with children, adults, parents, schools, and various organizations to help both children and adults improve their mental well-being and build the tools required to develop strong emotional regulation skills. Now, Anastasia, apart from the fact that you are a very good pianist, is there anything else you'd like to add about yourself?
I think that pretty much covers everything I need to say about myself.
Sorry, I can resist the piano comment. Still gets me every time. All right, so before we start the webinar, quick housekeeping items, particularly relevant if this is your first session with MHA. So first thing you'll notice is that you can't talk during the webinar, but you can use the chat and Q&A tabs to interact with other attendees and our team during the presentation and ask questions for our Q&A segment, which will be at the end of the presentation. The session is also being recorded, and a link to the recording will be available via the event portal shortly after the conclusion of the live webinar, along with presentation slides and a handout. So if you are in the middle of this session and suddenly there's a fire in your school and you have to run out, don't worry, you can catch up later via the on-demand. And finally, to download a certificate, go to the event portal after the session. You will see a certificate button there. It's currently disabled, but it will be enabled at the end of the live webinar. And you'll be able to complete an evaluation survey and download a PDF copy of your certificate. All right, that's enough explanation. It's time for the presentation. Anastasia, I'm going to hide myself here and be quiet on the background, but I'm looking forward to the presentation, and I'll see you here for our Q&A later on.
Lovely. Thank you so much, Pedro. It's so lovely to be here with you all today, talking on a topic that feels very close to my heart, which is working with children and adolescents who have intellectual disabilities. This is actually the area that I did my PhD research in, and an area that I continue to do ongoing work, both clinical work and research in, and certainly an area that I think hasn't had a whole lot of sort of clinical research applied to it. A lot of the work that has been done in this space has been sort of adapted from maybe the work that's been done with individuals who have a diagnosis of autism or neurodivergence. But I feel like it's really important to specifically focus on how we can best work with children and adolescents who have intellectual disabilities. So as we go through the session today, I'll be providing an outline and framework as to, a diagnosis of an intellectual disability, what that means for a young person in terms of how their cognitive abilities may be negatively impacted as a result of this diagnosis, looking at sort of some of the comorbid mental health conditions that we commonly see for kids with disabilities, and then, of course, looking at how we can therapeutically work with children with intellectual disabilities, both inside and outside of the classroom. A lot of the strategies and suggestions that I'll be talking through are things that can certainly be delivered by clinicians, but have also been used by teachers in classrooms, whether that be applying these approaches from a group class perspective, or whether it be sort of one-on-one individual applications for suggestions to help these students. But really kind of coming at it from the perspective of the mental health and well-being of children with intellectual disabilities. I don't need to go into myself again, but just to sort of highlight that what I'll be presenting today is a combination of work that comes from both my clinical practice, but also my research and work in academia, specifically looking at evaluating interventions for young people with intellectual disabilities. So when I set out to do my work and my research in working with kids with intellectual disabilities, we worked with many families where there was a child with a diagnosis of an intellectual disability. And one of the most common stories that I heard was this story of young children falling between the cracks. And what I mean by that is a family would come to us at the clinic and they would say, you know, I went to a disability service trying to get mental health support for my young child who has an intellectual disability but co-occurring mental health condition. We went to the disability service and they said to us, oh no, you want mental health support, you need to go to a mental health service. And so we would then go to a mental health service and the mental health service would say to us, oh, your child has a disability, you need to go to a disability service. And there was this back and forth, very common story that we heard from the majority of the families that we worked with, where subsequently what would happen is they would often end up falling between the cracks of services. And so my goal in working with families, but also developing some of the research and guidelines in this area has really been to build the confidence of anyone working with young people with intellectual disabilities, to be able to build on the skill set that they already have and have the confidence and the competence to be able to work with this population of young people. Because often what we have found is that it's not that an individual clinician or teacher or counsellor doesn't have the skills to be able to do this work. It's that they sometimes lack the confidence to be able to translate the skills that they have so that they are effective and applicable for children who do have intellectual disabilities. Now, when we are talking about an intellectual disability, we're talking about a person who has this diagnosis that's characterized by two key features. So the first one is that they have a significant impairment in their intellectual functioning, which is usually measured and assessed according to some sort of test of IQ. But they also have significant impairments in their adaptive functioning. So this is their ability to engage in day-to-day living skills, which we'll go through in a moment. Historically, though I will explain that there's some variation around this, but historically we have looked at the intellectual functioning and deficits in intellectual functioning as being diagnosed as someone who has an IQ level of under 70, although there is some variability with that these days. But they also have these difficulties with everyday tasks required for general living. Now, an intellectual disability, in terms of our categories of diagnoses, it's classified as a neurodevelopmental disorder. These neurodevelopmental disorders essentially have an onset in the developmental period. So an intellectual disability would be diagnosed differently compared to someone who perhaps has suffered from a traumatic brain injury later on in their life, where they do result in having some cognitive impairments, but it wouldn't be classified in the same way because an intellectual disability would require the onset in the developmental period. So when we say the developmental period, we would be assuming that a young person presents with these difficulties in their cognitive abilities before they enter sort of grade school. And they're also experiencing these difficulties with perhaps social interactions, day-to-day tasks that would be developmentally appropriate for their age. Often we see these difficulties present in areas that require a level of executive functioning. So when I am talking about executive functioning, I'm talking about the prefrontal cortex of the brain, front of the brain, that helps us do tasks such as planning, managing our time, organizing things, problem solving, etc. And as these would apply, problem solving skills, management skills from a very early age all the way throughout life. So these difficulties in intellectual kind of and cognitive impairments would present and manifest as perhaps difficulties with reasoning, problem-solving skills, planning, abstract thinking, so the ability to think quite conceptually about things rather than very practically about them. Impairments perhaps in judgment and reasoning, so making sound decisions based on being able to make judgments. Of course, academic learning, and then also finally this sense of learning from experience. So if we go through particular experiences in life, am I able to take away learnings from those experiences and then use that information, integrate it into my existing knowledge system and help and use that information to help me make decisions in the future? So if a young person is not able to kind of meet these requirements, and, you know, they sound like quite complex things, but again, we're looking at age expected, you know, what we would expect for someone of a particular age. So this might be for a 4-year-old. How would we expect a 4-year-old to actually problem solve, reason, and learn from experience? This would be different to a 10-year-old and so on. So if they're not meeting their developmental milestones in the way that we would expect, we would be looking at a diagnosis of an intellectual disability. So according to our diagnostic manual, our DSM criteria, in order for an intellectual disability to be diagnosed, we're looking at a young person meeting these kind of 3 criteria, A, B, and C, that are listed there. So they need to show deficits in those areas of intellectual functioning, as we've just gone through, around reasoning and problem solving. And that's assessed typically by standard intelligence testing. So this might be something like the Wechsler WISC, for example. The second criteria is that a young person shows deficits in adaptive functioning, and we'll go through a little bit more in detail what these look like at different developmental ages. But they're exhibiting a failure to meet the developmental and social standards that we would expect when it comes to tasks like personal independence and social engagement. So this might be things like how they can communicate with other people. Are they able to participate socially? Are they able to show milestones that they're developing independent skills of being able to look after themselves? So, for example, being able to brush their teeth, dress themselves, etc. And we look at this being a difficulty across multiple environments. Now, this is really important when we're looking at any kind of neurodevelopmental disorder, whether that be autism, ADHD, an intellectual disability, etc. We need to see consistency across environments. If we are not seeing that consistency across environments, then this may be an indicator that there's some other perhaps mental health concern or environmental concern going on for this young person. I digress slightly, but this is a major factor that we look at when diagnosing ADHD, with or without an intellectual disability being present. If a young person is only showing signs of inattention or hyperactivity in particular contexts, for example, at home, but not at school, then we need to sort of also consider differential diagnoses for why this might be the case for that young person. So we have the deficits in intellectual functioning, deficits in adaptive functioning, and then, of course, finally, this onset of these difficulties need to occur during that developmental period. Now, we do have specifiers in terms of how we would diagnose an intellectual disability that are based on adaptive functioning, not IQ scores. Now, historically, it was based on IQ scores, but we have shifted away from that to focusing on diagnosing levels according to adaptive functioning, because it's often the adaptive functioning that determines the level of support that an individual is going to need in their life. Also, IQ scores, you know, the lower down the IQ spectrum we go, the less valid the IQ scores become as well. What I will say is that historically we have looked at these kinds of categories for diagnosis according to IQ scores. And this is just important to note if you are ever reading any literature around intellectual disabilities, because IQ scores can be a neat way to categorize people for the purposes of doing evaluations and research. So you will often see that intellectual disabilities are categorized in these ways for the purpose of being able to do those evaluations. So as we said earlier, a IQ score of 70 or under 70 is a requirement for being diagnosed with an intellectual disability. I will say that there is always a confidence interval that applies to that score. So someone could potentially be scoring 71, 72, 73, but still kind of be classified with an intellectual disability because there is a small amount of variation that we do allow for. If an individual is scoring in the kind of 70 to 80 range on an IQ test, keeping in mind that 100 is the average, if we're looking sort of 80 to 90, that's sort of low average, but 70 to 80 is what we would classify as being in the borderline range. Now, if I just speak to these young people for a moment, these are children that are often in mainstream classrooms. They're children that are often struggling academically with the work that they're being presented, yet they don't quite meet criteria for being able to have a diagnosis applied, and therefore are not necessarily able to access additional funding or additional supports perhaps. So they are a group of children who are quite vulnerable to developing mental health concerns, particularly low self-esteem, high levels of internalized self-criticism, and quite negative views of themselves, because they fall into this kind of middle bracket and category where they don't necessarily have the diagnosis where specific supports can be implemented, but they are still struggling in many ways. So once we meet that sort of 70 IQ mark, below that, we're looking at a classification of either a mild, moderate, severe, or profound intellectual disability. With mild to moderate intellectual disabilities, we are really talking about typically a cohort of individuals that can communicate, so not without difficulty, but there are verbal abilities. If someone has a mild intellectual disability but perhaps has another diagnosis such as autism, we may see that that differs. But if we're looking at an intellectual disability on its own, then typically the mild to moderate categories of diagnoses, we would expect a young person to be able to have communication skills. Severe to profound, these are certainly impacted more so. Particularly with verbal communication. It's not to say that we can't also implement other aids and resources, such as visual pictures, etc., where we can assist someone to communicate in a way that works particularly well for them. That said, the prevalence of a mild intellectual disability is much higher than those with a severe intellectual disability. So we're much more likely to be coming across and having in our classrooms children who might be in that sort of borderline to mild kind of range of intellectual disabilities. If we look according to criteria of adaptive functioning, I've taken this out of our DSM manual, but we're looking across these three domains for difficulties a young person might experience. So this table that I've got here is for a severity level of a mild intellectual disability, and we can see it's broken into conceptual, social, and practical domains. So in terms of sort of a conceptual domain, I quite like these tables because it goes through different rough age levels as well. So for young preschool children, we might not actually be able to identify any differences in conceptual differences, and it's not until they reach school age that we're able to identify more difficulties with learning academic skills like reading and writing and maths, but also the more abstract thinking that a young person starts to engage with as they go through the learning process at school. What we find is that perhaps children with an intellectual disability in the mild range might typically be more rigid in their thinking than a young person who doesn't have an intellectual disability. So there is what we refer to as a lack of cognitive flexibility. And the thing about cognitive flexibility is that it's a huge protective factor against mental health problems. The more flexible I can be with my thinking, overall, this applies for all of us, the more flexible we can be with our thinking, the better off we are in terms of our mental health and well-being. It's when we identify people who fall into very rigid patterns of thinking and rigid ways of approaching things that we see more mental health difficulties occur. So unfortunately, this means that young people with an intellectual disability, by nature of some of that rigidity, are more vulnerable to developing mental health concerns. We also see these deficits in the social domain, where there might be difficulty sort of communicating, having conversations, but also, not necessarily understanding risks in social situations, difficulties with regulating emotions in social contexts. So it's not just necessarily about the ability to make and keep friends, but also in interactions and conversations, that emotion regulation capacity that's required as well. And then, of course, in the practical domain, we're looking at how these develop over time. So for a young person, this might be things like, can they brush their teeth? Can they dress themselves? Can they pack their school bag? Can they get their homework out when they come home from school? These sort of practical tasks for daily living that's appropriate to the age that we would expect for that young person. As we go according to severity levels, you'll see in the more moderate range, again, you'll be able to have access to these slides to read through them in more depth, but we are seeing more sort of moderate concerns, again, with academic skills as part of that conceptual domain, but also with the social domain, struggling with social judgment and decision-making when it comes to social interactions. We might see that children are more likely to develop friendships with peers that are younger than them or in lower kind of age, lower grades than what they are. And then in practical domains, we just see a higher level of intervention required from caregivers, from parents, from carers, from teachers, aides, etc., to be able to kind of do those daily living tasks or have some of those completed for them. Finally, we have the severe and profound categories, less likely to be, very unlikely to be in sort of mainstream classrooms. These children would be more likely to be in sort of specialist schools where their needs are catered to, and they're able to have more consistent and high levels of care as required. Again, we typically would see great difficulties in communication skills here, particularly verbal communication. One thing that is important to note as we move on from the kind of diagnosis of an intellectual disability, but something important to note here is that an intellectual disability is often co-occurring with other neurodevelopmental disorders. So, for example, we see high levels of intellectual disability occurring with ADHD and autism as well. And as I talk through this whole presentation and the work that we've done around assisting kids with intellectual disabilities, keep in mind that the kids we have worked with, many of them have had these co-occurring diagnoses of particularly ADHD and autism. So it's not to say that the strategies that I suggest are required for just someone to have an intellectual disability and no comorbid neurodevelopmental disorders, but they absolutely can apply to those who have more than the one diagnosis. So it's important to note that if, though, a young person is diagnosed with an intellectual disability, we wouldn't also necessarily diagnose them with something like dyslexia or a reading disorder or a maths disorder or a writing disorder. That's only if a young person is in a category where they are intellectually sort of performing in like average or low average or even high average categories, but that their reading, writing or math skills are significantly lower than what we would expect compared to their intellectual functioning. So the diagnosis of a specific learning disorder always needs to be in comparison to what their intellectual functioning is. So that's why if we have a young person with a mild or moderate intellectual disability, we wouldn't then also diagnose something like dyslexia or a specific learning disorder. Now, if we start to move more into talking about the mental health of young children with intellectual disabilities, we've sort of talked about the diagnosis of the intellectual disability. But if we look more at the mental health side of things, it was actually previously believed that people who had an intellectual disability could not experience a mental illness and that they were largely unaffected by adverse life experiences because of their limited cognitive capacities. unfortunately, well, fortunately now we know the opposite is actually true, but unfortunately it is actually true. It is actually the case that people who do have intellectual disabilities are much more vulnerable to experiencing mental health concerns, and they are often more adversely impacted by stressful life experiences and adverse life experiences. So when we look at the statistics of people who have an intellectual disability and a comorbid mental health concern, approximately 35% of adults who have an intellectual disability will also have a co-occurring mental health condition. And for children, it's about 50% who will also have a co-occurring mental health condition. So quite high rates, particularly when we compare to the general population. Now, not only do, unfortunately, these people have a high proportion of them have a mental health concern, what we also know is that a very low percentage of them access mental health services for treatment. And that's for a number of different reasons, but they have low rates of accessing treatment. If we think about risk factors that make a young person with an intellectual disability, more vulnerable to developing a mental health concern, there are quite a number of risk factors. So first of all, there's biological risk factors. So by way of how the intellectual disability has come to be, for example, if there's some sort of genetic mutation, if there has been some sort of traumatic brain injury at birth, for example, by nature of the biology of the individual, they might be just simply more vulnerable to developing mental health concerns. But there are also psychological risk factors. So this is largely around what I mentioned earlier, and that cognitive rigidity. The more rigid an individual is in their approach to things or in their thinking, the more at risk they are of developing mental health concerns. So they, by nature of the kind of more rigid style of thinking, are more vulnerable. We also see that there are adverse life experiences. We know that people with intellectual disabilities have higher numbers of adverse life experiences. We see high rates, for example, of trauma and other difficulties, for example, coming from a low SES background, experiencing poverty, experiencing homelessness, etc. So people with an intellectual disability have high numbers of adverse life experiences, and this again makes them more vulnerable to in turn developing a mental health condition. We also know that there are lifestyle factors. So again, for example, people with intellectual disabilities typically have higher rates of obesity. They also can have quite concerning drug and alcohol use at times, high rates of smoking, etc. So there are lifestyle factors that can make them more vulnerable. And then environmental triggers. So this one largely comes down to control. Unfortunately, it is not an uncommon experience for people who have intellectual disabilities to experience less control in their life than those who don't have an intellectual disability. So, for example, as a person with an intellectual disability, might enter housing that is not their own kind of family home, whether this be for respite or whether this be as they get older and they enter a sort of living facility. They may not have a whole degree of control as to who they get to live with, where the location of that housing is, etc. They're often kind of placed in these environments. This also applies for young people who perhaps are placed in environments for respite when carers and families are requiring that respite. They may feel like they don't have a whole lot of control and choice over where they're able to go. So it's important to keep in mind that not having control or not feeling like we have control for all of us is quite a significant risk factor for poor mental health. And by nature of the ways in which many of our systems work to try and support people with intellectual disabilities and their families, it may be that a young person or an adult with an intellectual disability ends up having less control over their life. And as a result, these environmental factors that make them vulnerable to the difficulties that they might face with their mental health. Now, When it comes to accessing supports and treatments, less than 10% of kids with intellectual disabilities are actually accessing the mental health supports that they need. There can be a number of different barriers. It can be things like poverty or socioeconomic barriers. It can be communication barriers. So maybe that young person themselves doesn't know, doesn't have the language, doesn't have the capacity to be able to communicate what's going on for them. Or perhaps the carers in their life don't quite have the knowledge or the language to be able to communicate that. Unfortunately, we do see this pattern of stigma and exclusion from services. So as I mentioned earlier, this idea of going to a disability service and being told to go to a mental health service and vice versa. There are also, as it exists, both here in Australia and overseas, not that many services that are developed and exist to support young people who have both an intellectual disability and a mental health condition. Mainstream services are typically not very well equipped to help them. Carers might not know how to communicate or lack an awareness of the symptoms. And again, perhaps services themselves don't communicate very well and are not particularly cohesive in being able to support a young person. Now, I won't go through typical symptoms of a mental health condition because I think this may already be common knowledge for many people watching. But what I do want to touch on is that there are potential atypical symptoms of a mental health disorder for people with intellectual disabilities. Now, these are more likely to present the more severe the intellectual disability is. So for a young person with a mild intellectual disability, we would be more likely to see more typical presentations of things like anxiety, depression, stress, PTSD, etc. The atypical presentations for mood are more common for those who have the more moderate, severe, and profound intellectual disabilities. So this is things like expressions of poor mental health through aggressive behaviour. So if we are working with a young person who has a more moderate intellectual disability that's showing high signs of aggression, it's important to formulate and conceptualize this behavior through the lens of mental health concerns rather than oppositional behavior. We're more likely to see self-injury. This is self-injury not necessarily with the intent to end life, but rather to harm oneself or to regulate one's own emotional experience. So it might be biting, sucking, hitting, picking at scabs, or if you've ever seen a young person who sort of has scratched themselves a lot where scabs have developed and they keep picking at that. So again, a sign of perhaps a mental health condition that is not able to be expressed in other ways. Selective mutism is quite a common one, with experiences of a young person withdrawing or selectively ignoring people, refusing to participate in certain activities, high rates of insomnia, and also high rates of avoidance. Some of these that we see in more typical presentations as well, but the couple that I would say I would typically see for more moderate intellectual disabilities is the aggressive behaviour, the self-injury, and the selective mutism, those top three. Just from my clinical work, they appear to be three very common ones where those symptoms may be seen but perhaps overlooked as indicators of a mental health condition. I think it's important to talk about the need for these signs and symptoms to be recognised and for interventions to be developed and delivered, because as part of the work and research that I did in this space, we actually spoke to a number of different clinicians, surveyed different kind of people, and not just psychologists, anyone kind of working within the field of mental health for people with intellectual disabilities. And this was a study we did in Australia, but it was adapted off research that has also been done in the UK with very similar findings. And I won't go through the numbers in this table, but what I will do is just highlight that what we found was that people who work with intellectual disabilities are generally quite confident with what I would refer to as the kind of micro-counselling skills. So this is the ability to listen to a young person who has an intellectual disability and listen to their concerns, work with the family, work with the caregivers, provide empathy, show empathy, these micro-counselling skills. But people are less confident when it comes to knowing how to choose appropriate tools to be able to measure a young person's well-being or mental health. They're less confident when it comes to knowing how to actually intervene to help them, how to choose between what sort of interventions either in the classroom or in the therapy room would be most effective for them. So these kind of more applied clinical skills, people feel less confident when it comes to being able to use these, which is why we decided to do this body of work around helping manage young people with intellectual disabilities, so that people working with children who had these disabilities felt more confident to be able to adapt their existing skill set to meet the unique needs of children with disabilities. I want to also highlight another reason why this is important if we step away from young people with mental health and take a bigger look at the picture that we're faced with. This is, I'm going to provide some Australian specific data, but I want to say that the research shows that this is not too dissimilar when it comes to countries overseas, particularly the US and the UK. So in Australia, we actually have a national roadmap that's been developed for helping people with intellectual disabilities. And the reason for this is because people with intellectual disabilities have much poorer health outcomes. And when I say health, I'm not just referring to mental health, I'm talking about all types of health. They have much poorer health outcomes. And the data shows us that people with intellectual disabilities have more than twice the rate of avoidable deaths. They have twice the rate of emergency department and hospital admissions. They have significantly higher levels of both physical and mental health conditions, and they have significantly lower rates of preventative healthcare. And this last one they're all really important, but this last one really stands out for me because when we work with young people, when we get the privilege of working with young people, we have the ability to do some of that preventative work with them, to be able to identify concerns early, diagnose early, and be able to provide supports and interventions early as well. And we know that early intervention is such a key indicator for positive outcomes later on in life. We also know that for many people, the diagnoses from childhood don't necessarily remit unless intervention is provided. They won't necessarily just get better without treatment. If anything, they run the risk of it getting worse. So again, this kind of health inequality and inequality in terms of mortality rates, we see it across people with intellectual disabilities across different countries. So in Australia, if you don't have an intellectual disability, the average life expectancy is about 83. But if you do have an intellectual disability, it's about 58 to 75. And if you're in the UK, it's even lower. It's about 40 to 62. So we do see these significant discrepancies. And as I say, we're really looking here at the preventable part, that many of these deaths are avoidable, that many of these health concerns are avoidable, or the development of these health concerns becoming as bad as they has been avoidable at some point in the way. This roadmap also interviewed people with intellectual disabilities to be able to provide I guess the lived experience perspective of what people with an intellectual disability want from people who are supporting them in their life. And they really speak to, we all need to be treated the same as everyone else. We want the same respect. We want people to take time with us, to explain things properly and clearly, be patient and be respectful. We want great healthcare, and we want to have the same quality of life as everyone else. So I always like to talk about this because I think it's important to put in perspective, while we might be working with young people in the classroom who have an intellectual disability, it all starts somewhere, and the path to getting the relevant support and services and treatments starts somewhere. And I think often it is the case that those working with a young person, particularly teachers and the school environment, are in such a privileged place to be able to see how a young person interacts, as well as the difficulties they might be facing, and be in a position to perhaps suggest additional supports for them as well. This is really where our stepped care models of intervention come in, and a lot of the work that that we have done has been around providing treatment, but a lot of this can also be delivered as early intervention. So when we think about stepped care models, we're really talking about giving the right intervention to the right person at the right point in time. And there's three key elements to stepped care models. This idea that a person's needs change over the time. We need to deliver an intervention that meets them exactly where they're at. And we don't need to start at sort of level one and move through all the different levels to provide an intervention that works for them. So if I give you a bit of an example of what this looks like, with stepped care models in mental health, we look at, how do we support a well population, a population that doesn't have mental health difficulties on the left-hand side, and then how do we support those who are at risk? They don't necessarily present with significant mental health difficulties, but they have the vulnerability factors, they have the risk factors present for them. How do we support them? And then move our way through more mild, moderate, and severe mental illnesses and mental conditions to be able to provide the appropriate support needed for those people. Again, I come back to young people in a classroom are where we can really sort of identify challenges and difficulties. And I think teachers are in a great position to be able to see how children interact with others and see how they are in their day-to-day life, because there is a sort of comparison point to other children as well. Often what we would hear from a lot of the families who had children with intellectual disabilities and perhaps didn't have other children as well is that they didn't have a benchmark for what they perhaps would perceive as to be expected or kind of common behaviour for a young person. If a child is not necessarily able to communicate in the ways in which they're struggling, and a parent is not necessarily able to identify that either, it's an easy way for kids to slide under the radar and for these challenges to get worse over time before they do seek some support. So the prevention is so important. We see this also with adults with intellectual disabilities when they go to visit doctors or a general practitioner. So when they go to visit a doctor, the doctor often doesn't get to do much of the preventative screening that they would for other people. They don't necessarily get time to be able to do the preventative, breast screening for cancer or other types of things like this that are preventative, because there is so much else that they're helping that person with. But unfortunately, the lack of preventative screening and care might mean that other issues develop to be much more serious and significant in their life. So as we are looking at these kind of stepped care models, we want to look at how we provide those sort of interventions at different stages of time for different people. So whether that be well populations, interventions for at-risk groups. So this is really where I think we focus this presentation on an at-risk group. People who have an intellectual disability are at risk by nature of the reasons we've discussed. And this is where a lot of education about mental health, preventative strategies, and interventions via carers and family members can also be really effective. We can also look at integrating more digital healthcare solutions for those who are struggling with mental health concerns. And we'll talk about the program that we've developed that is the program I'll talk about is freely accessible for anyone to use, but there is an online website component of it so that children do have that engagement when it comes to going through a therapy program. So one of the most effective treatments that we have as working in the mental health space is that of cognitive behaviour therapy, or CBT for short. There's, of course, a kind of third wave of cognitive behaviour therapy that has come through. So this is like our mindfulness-based interventions, our ACT, acceptance and commitment therapy-based interventions. So there's a third wave that's come through, but its roots is in cognitive behaviour therapy. And this is useful to be across not only when we're providing treatment, but also when we're providing more preventative interventions to understand how, the human experience works to link different elements together. So in cognitive behaviour therapy, we're really looking at the links between our cognitive experiences, so our thoughts thoughts exist on different levels. So we're looking at those automatic thoughts all the way down to our more sort of deep-seated beliefs that we might have about ourselves, others, and the world. But there's an element of cognition. There's an element of emotion, so our feelings and our emotional states, both how they feel, but also practically how they present in the body. You know, how do I actually notice signs of emotions in my body? And then, of course, there's our behaviours. What do we do, as a result of these thoughts and these feelings? So we know that our thoughts, our feelings, our behaviours are all connected, and they all influence one another. And from a cognitive behavioural perspective, we can provide strategies to manage thoughts, we can provide strategies to manage big feelings, and we can provide strategies to help us change our behaviour. But essentially, cognitive behaviour therapy is very changed focused. We're looking at helping an individual change either 1, 2, or 3 of these elements in the cycle. Now, historically, because young people and adults with intellectual disabilities had difficulties with their cognitive capacity, it was kind of assumed that they couldn't do the more cognitive work. They couldn't actually do or engage with strategies relating to thought processes. So the focus was on purely behavioural interventions. So if anyone has heard of like ABA therapy for kids with autism, for example, this is a very practical behavioural intervention where we really just look at providing structures and reinforcements to modify behavior. So this would be things like reward systems, visual schedules, positive or intermittent reinforcement schedules when kids do behaviors that we want to see them doing more of, etc. So it really focuses on practical behavioral changes. Now, these are effective. They do work. They can be very helpful both in and out of the classroom. And there's lots of good research and evidence supporting them. So we know that pure behavioural interventions can work. But what we kind of have looked at doing in more recent years, and this is what a lot of my research has been focused around, is, okay, let's not just make the assumption that because someone has some difficulties with their cognitive abilities, that they can't also engage with thoughts and beliefs on some level. And maybe we need to provide the right scaffolding, the right structures, and the right intervention for that young person to be able to do more cognitive work. Remembering that we talked about cognitive flexibility and cognitive inflexibility before. Targeting cognitive flexibility as a treatment outcome, as a therapy outcome, as a protective feature for a young person can actually be really important. So I guess a lot of this is around not making the assumptions that due to limited cognitive skills, that kids can't necessarily do the more cognitive work. Now, about sort of 10 years ago, there was research that was done with adults with intellectual disabilities, and it did show that they can identify thoughts, feelings, and behaviors. They can make the differentiation and distinguish between thoughts, feelings, and behaviors, and they can also make the links between them. Now, if a person can do these 3 things, if they can identify, distinguish between, and make the links between thoughts, feelings, and behaviors, then they have the foundation that's required to do something like CBT, or to engage in more cognitive-based strategies. So if we can get people to develop these skills, or if they're already able to do these things, then we know they can do more cognitive-based interventions. And there's good evidence to show that in recent years that CBT, cognitive therapy, can be adapted for adults with intellectual disabilities. So what I'm going to unpack in a bit more detail is how we can apply this for children with intellectual disabilities. Now, if there's one research paper that I suggest people read, and we can absolutely send this out with the copy of the slides that will be available as well. This paper is freely accessible online, but I'm happy to provide a copy. It is a review of the cognitive impairments that kids with intellectual disabilities have and how therapy or therapeutic interventions might need to be adapted to meet their needs. So what we do is we look across these 5 key neuropsychological domains where we know that children with intellectual disabilities struggle. So we look across learning and memory. Here, when I refer to memory, I'm talking about both short-term and long-term memory. We look at attention and different types of attention. So, for example, a young person being able to sustain their attention versus being able to split their attention. We also look at working memory. So this is the ability to hold information in my mind, but also work with it or manipulate it at the same time. We look across the domain of language and reading. And then finally, we look at executive functioning. So that's that ability to plan, reason, problem solve, manage impulses, regulate emotions, etc. So we look at these 5 neuropsychological domains. We look at what are the challenges that are present in these areas and how can we adapt our interventions to meet their needs due to these challenges. So I'll go through these briefly, and if there's anything that my face is covering here on the side, you will be able to sort of see this all fully in the slides. But for example, when it comes to attention, we look at perhaps providing shorter sessions. So is it that tasks need to be broken down into shorter tasks? Is it that we need to include more breaks for a young person? Is it that we need to have minimal distractions in the room when we're trying to work with this young person who has an intellectual disability? Is it that we need to use a variety of modalities, colors, different kind of things to grab attention and keep attention, but also attract attention? We also look at this idea of starting with person-oriented tasks and then moving to task-oriented activities. So what I mean by this is I will have better success at engaging a young person and teaching them a skill if I'm able to get them to engage with me first, so person-to-person engagement, before I move them on to then doing a task. So that could be, coloring, writing, drawing, whatever it might be, something task-based. It's always best to start with person-oriented activities before moving to a task-oriented activity for the purpose of attention. It will often be easier for a young child with an intellectual disability to sustain their attention when they're focused on you versus focused on a task. When it comes to learning and memory, we of course want to be checking in frequently to make sure that a young person is understanding what we're teaching them. We want to help them master the first part of a skill before we build on that and help them learn the next skill. Often in the therapeutic context, I might record sessions so that the young person and the carer can go home and review them, or at least parts of activities that I want them to practice at home. We want to involve the carers as much as possible so that they can facilitate that learning at home. And also really kind of engaging reality-based teaching, so learning via doing. From a psychological framework, this can sometimes be a little bit hard because so much of our job is talking, but really kind of embracing reality-based teaching and modeling the teaching. So this is, I'll often do this through a think out loud process when I'm modeling something to a young person with an intellectual disability. So actually talking out loud what my thought process is so that they can learn via that modeling. When it comes to working memory, we want to help a young person by having sort of short, simple sentences and often a kind of subject, verb, noun sentence. We want to present material both verbally and visually. So even when I am working with young kids with intellectual disabilities who can't read, I will still use words a lot of the time. I love to use a whiteboard, and kids tend to love drawing on a whiteboard as well. So I will sometimes write out words, but I won't do it with the expectation that the young person can read it. But what we do find is that they can sort of learn specific words that we use as catchphrases as we go through therapy programs, and they can refer back to these and identify that, okay, what Anastasia has written on the board refers to my feelings. So that those can be matched up. We also find that, presenting one activity at a time and really breaking down tasks into their smallest units and building from there helps with any difficulties with working memory. But the key thing here, I think, is really being able to provide the variety of aids, so both kind of written or visual aids, as well as kind of verbal information as well. Reading and language adaptations, it's always best when we work with a young person who has an intellectual disability for them to sort of be facing the therapist as much as possible, whether this be to be able to kind of read lips if that helps, or whether it be to sort of sustain focus and attention. There is easy reading text formatting. So there are guidelines on creating worksheets or handouts that are in easy read format. Also, things like Word documents will be able to provide you the reading level and age level that you've written something, if you do want to look at adapting it for a person who might have lower reading or lower cognitive abilities. Being mindful of having short sentences containing a single concept, and also like a particular contrast of text and page color. Unfortunately, this is something that I've heard a lot of the time from kids and adults with intellectual disabilities that maybe is not the first thing that comes to mind when people are creating resources and want them to be colorful and things. But if there isn't enough contrast, it can also create difficulties for language and reading. Finally, when it comes to executive function and the difficulties that young people can have with executive functioning, this is where the teacher, the therapist, the counsellor, whoever's supporting the young person can really take the initiative to plan and structure activities and tasks so that cognitive load is reduced from the young person. Visual schedules are also particularly helpful in these scenarios, because being able to present a visual schedule can mean that the young person can follow along without having to hold that information in their mind. Also, minimizing between task switching as much as possible. When I'm working with a young person, I will sort of set an agenda for the day so that they know what to expect in our time together, but really sort of focusing on minimizing switching between tasks as much as possible. So the first half of our time together will be spent doing X, the second half will be spent doing Y, and clearly communicating that to them. Again, as we said, like with executive functioning, we really want to actually target flexibility and problem-solving skills as an outcome. It's not necessarily just about kind of helping support the mental health outcomes of young people with an intellectual disability, but also looking at how we can help build their cognitive flexibility and their problem-solving skills. Again, thinking through that lens of prevention, and early intervention, if we are able to help young people develop these skills, this will serve them very well as they go through life and they face certain challenges or adverse experiences in life. They'll be better equipped to be able to do that if they have that skill of cognitive flexibility that's been developed. So ultimately, when we are looking at trying to adapt the work that we're doing with young people with intellectual disabilities, we kind of want to integrate typical adaptations that we would include for a child, typical adaptations we would include for the individual person that we're working with, and then, of course, adaptations for intellectual disabilities. And it's the intersection of these three areas that we're looking at providing strategies that can support that individual person. So what I want to turn your attention to now is something called the Fearless Me program. So this is a program that was developed through the University of Technology, Sydney. All resources attached to this program are freely available online. If there's ever anything you can't find that you're looking for and you can't find it online, just email me and I can send something out to you. But resources will be available with these slides as well. So the Fearless Me program was originally designed to help young people who have an intellectual disability but also anxiety. But from there on, the skills and strategies that we teach have been used in a number of different ways to help children with intellectual disabilities just develop those cognitive and cognitive skills, the emotion regulation skills, and those behavioral changes as well. So there is an online website for it. However, this is not a standalone online self-help kind of program. It's designed to be delivered with the assistance of someone, whether that be a therapist, whether it be a teacher, whether it be someone who's got some ability to support a young person through it and their family through it as well. But we have run the Fearless Me program in one-on-one sessions with young people, but we've also run it in classrooms as well, with classes where children have intellectual disabilities. So I've done this with a number of schools where we had children with mild to moderate intellectual disabilities and a few in the borderline category. And with the assistance of a teacher's aide, we were able to sort of deliver this mental health program to support their overall psychological well-being and develop those tasks of skills of cognitive flexibility and problem solving. So there's three kind of categories of activities, and these are structured around those three pieces in that CBT model that I showed you earlier: the thoughts, the feelings, and the behaviours. So the Keep Calm module is all about emotion regulation. And really, when I talk about emotion regulation, there are a number of steps to emotion regulation, right? We're talking about the ability for someone to notice that they're having a feeling for a starting point, being able to identify what that emotion is, understand how and why it might be coming up in the body, because often emotions are trying to communicate a message to us. You know, they exist for a reason. They're sources of data and information for us, and can often be quite helpful messages for us to listen to. So we need to understand the emotion. And then once we have been able to identify, understand it, we then do something to regulate it, to manage it. And this is where our emotion regulation strategies come in. So our Keep Calm module is all about helping young people with intellectual disabilities learn the strategies to manage their emotions. The second part, which is the Stop and Think, is activities relating to building those cognitive skills. So this is all about being able to identify that thoughts exist, identify that I am having a thought, make a judgment as to whether that thought is actually helpful or unhelpful for me, and then engage with that thought to be able to challenge it, to be able to come up with a more helpful way of thinking. And then finally, we have those more behavioural strategies. So this might be something like, in this example, working to face fears. If I have a fear of something, if I'm avoiding something, how do I build a step-by-step pathway, practical behavioural pathway, to be able to overcome that fear? So when I work with young people in a clinical sense, and when we've done a lot of the research evaluations of this, we've done it across like a 10-session structured program. But I would say that typically for children who are on the more moderate end of the intellectual disability spectrum, that it may take sort of longer than this for them to be able to fully grasp all the skills and to be able to confidently use the skills independently. So I'm going to take you through a few more of the activities as these can be implemented in the classroom or with individual students or in groups to be able to assist them with their emotion regulation. Now, there are some videos on the website available. So we have a video that's around balloon breathing, which is essentially what we might refer to as box breathing, or what we just refer to as kind of deep breathing. The analogy here is that a young person kind of imagines a balloon blowing up and the air going out of the balloon. They sort of put their hands over their stomach, they breathe in and out and kind of have this visual aid and guide along with them while they do the practical exercises. We also have another video that's around what we refer to as progressive muscle relaxation, but we have called it squeeze and relax for the purpose of the program and for the purpose of teaching children these skills in a way that's accessible for them and easy to remember and understand. So essentially the progressive muscle relaxation, or the squeeze and the relax, goes through different muscles in the body and essentially helps a child learn emotion regulation strategies by tensing muscles. So we might say something in the video like, imagine that you have oranges between your hands and you're trying to like squeeze all the orange juice out of them. So you squeeze them for a period of time, you hold that, and then you relax it, and you notice the difference in terms of the feeling of tension. Similarly, there's another one where we say, imagine you're chewing gum, like big bubble gum, and you want to like clench down on the bubble gum. So you clench your jaw and you make that face and you clench it. You tense kind of the cheeks, the jaw, you hold that, and then you relax. So there's all these different little analogies that we use for different parts of the body to help go through that scan of the body and the progressive muscle relaxation as it applies to different parts of the body. And typically the way I would introduce this to a young person is to get them to just watch the video first and listen along, but then also for them to practice along while watching the video. As you can see, it's me there kind of doing these different activities, and so children can watch along and also participate in that as well. The next kind of module focuses a lot on those cognitive skills. And again, we have these activities on the website that can help children learn these different parts of being able to identify their thoughts and then challenge their thoughts as well. So this kind of module we refer to as stop and think. And there's sort of 3 subcategories to this. So the first one is think, feel, do. And I've got to say that this is the part that I typically find the most fun to do with children, particularly children with intellectual disabilities. And so this first bit is all about getting kids to be able to identify a thought, a feeling, and a behavior, and to be able to understand that those are different things. Depending on the age of the child, now typically we're working with kids 8 and up when we're doing this sort of work, but typically when we are working with children, they may not have had much exposure yet to thinking about their thoughts. Often we think and we don't necessarily question it. So the idea of being able to actually identify a thought might be quite new to a young child. And in fact, it's a very abstract thing, right? And we know that with intellectual disabilities, abstract thinking is not the strength of the skill set. So it can be sometimes a little bit challenging to teach. And I'll talk you through how I do that. But we can have a lot of fun with it. So where's my slide? Here we go. So what I tend to do, and I like to do this on a whiteboard because it just creates, I think, room to have a bit of fun with this, is I will actually write these 3 words at the top of the whiteboard. I know I mentioned before, I will sometimes write words, even if a young person can't read, and that's okay, because I will constantly refer to them as think, feel, do. And so with repetition, they do get to internalize that this is what I've written on the board. In order to get children to understand these 3 distinct concepts, I typically always start with the doing first, the behavior. This tends to be what I find clinically the easiest entry point into doing this kind of work. So a young child can typically understand that they do things. Now, I'll always start with examples. So what I want to do here is generate a big brainstorm list of all different things that we can do. So I'll say to a kid, for example, something that I can do is ride a bike. Something that I can do is brush my teeth. Something that I can do is write with a pen. What can you do? And then they might sometimes repeat the same things that I've repeated, which is not uncommon for working with kids with intellectual disabilities. But I will sort of prompt them to be able to generate ideas separate to what I have suggested. But this will be quite fun. It'll be like, I can jump, I can run, anything, any kind of behavior we can put on this list, and we'll either write them on the board or we'll draw up little pictures of them. But the idea is to make it, quite exhaustive and extensive. So once we've got that down pat, we've done the things that we can do, behaviors that we can engage in, we'll then move to feelings. Again, this seems to be the next easiest entry point that I find for young people that they can relate to or identify. And we'll again do a brainstorm of all the different emotions or feelings that they are familiar with. We'll draw these on the board. We might draw faces that go along with them Typically, I find young children, perhaps with an intellectual disability, may actually have received more intervention when it comes to emotions and understanding emotions than they have around cognitions. So this is kind of the appropriate next step after the behaviours. And typically, children are able to do this. We're just getting them to brainstorm different kind of emotional states. Now, after that, we do the think part. Now, I'll say that this kind of activity will take me at least sort of like 30 to 45 minutes with a young person. So we do spend a fair bit of time on it. But when it comes to the thinking part, oops, here we go. I've got extra slides. Yeah, so when we do the do, it's brainstorming things I can do. I can jump and clap. What are some things that you do? And then if the question is too broad, I will narrow it down to a specific context. What's something you can do at school? What's something you do with your little brother? What's something you do at home, etc. Then with feelings, brainstorming the feelings and drawing the faces. And then finally with thinking, I will sometimes use analogies like thinking is when we talk to ourselves in our mind or our head. Everyone thinks, we can think about different things. And then it's like an inside voice, although this doesn't always land because sometimes inside voice has been associated with not yelling and being quiet inside. So depending on what kids have been told about an inside voice, it may or may not land. But this is where I will start to introduce the idea that thoughts can be true or untrue. So I'll say something like, we can all think different things, and we can think things that are true, and we can think things that are not true. So typically the one I always start with young kids is I will say to them, for example, I could think that your hair is purple, and I'll say like an outrageous color that it's not, and they'll typically laugh and they'll be like, no, haha, no, my hair's not purple, my hair's brown. I'll say, oh, okay, so is that true or untrue? And they'll say it's not true. Okay, and I'll say, what if I have the thought that your hair is brown? Is it true or untrue? And they'll say, that's true. Okay, then I'll say something else that's kind of outrageous that I know that they'll know the answer to. I'll add. So, for example, I'll often say things like, I'm having the thought that we are standing on the moon right now. Is that true or untrue? I'm having the thought that this room is filled with a swimming pool full of water. Is that true or untrue? So I'll find things that are very obviously not true to be able to kind of give these examples with. And then things that are very obviously true. I'll say, I'm holding a water bottle in my hand. Is that true or untrue? So that they can easily give me the right answer. I will then ask the young person to do it back and to generate some examples back to me of things that are true or untrue. Again, typically they might use examples that I have already used. For example, I often get the hair one back, but maybe a different color. But essentially helping them kind of build this understanding that we all think things and those thoughts can either be true or untrue, and being able to generate these differences. Now, this will be helpful when we start to apply this perspective to their individual way of thinking about things, whether that be if they're feeling anxious about something, whether it be that they're catastrophizing a situation, whether it be that they're feeling sad. When we find these kind of patterns of unhelpful thinking, being able to talk to kids about true versus untrue thoughts will be useful to help us build that cognitive flexibility and challenge them on their thinking. But this is a really crucial first part. It can sometimes take a little bit of time, but it's a really kind of key milestone to get children aware of and understanding. Once we do that, we can, on the website, there are some activities where you can like practice identifying thoughts, feelings, and behaviors. So for example, there'll be a sentence and everything has a bit of a speech to text to speech function. So for example, it'll say like, Lucy's parents bring home a new puppy. What's the sentence that says what Lucy was thinking? So these are kind of best done if someone can sit with the young person and actually go through them with them together, because it might be easier to sometimes read things out loud or be able to work through the scenarios in that fashion. But essentially the young person clicks the feeling, clicks the thought, and clicks the action or the behavior that they engage with. So this is this idea of practicing. We always start with scenarios that are not specific to that young person's experiences. So these examples that are not about their own emotions, their own actions, or their own thought processes, it's important to start with other examples, because it can be harder to apply the skill set when it applies to their own individual experiences. We will come to that, but we don't start there. Building from this, if we can get a young person to be able to identify those thoughts, feelings, and behaviours, we can then help them identify some unhelpful patterns of thinking, which we all fall into the trap of at time to time. But we might find that a young person, for example, with anxiety, might be more likely to catastrophize certain scenarios. So we look for these kind of patterns in unhelpful thinking. We call this thought catching. So essentially what we want to do is help the young person identify maybe a worry thought versus a helpful thought. So we can, I typically start doing this on the whiteboard again. I love the whiteboard. I'll draw a scenario. So it'll be like some kids laughing at school, and I'll draw some little people laughing at school. And then I'll do 2 thought bubbles. What's a thought that would help me feel calm if I saw other kids laughing? And what's a thought that might make someone feel anxious? Again, it doesn't have to be the personal scenarios. It can be just made up scenarios where the young person can apply these skills, and they might say something like, if someone saw kids laughing, they might think they're laughing at them versus it being a funny joke. So which one would be the worry thought? It would be thinking that they're laughing at me. So again, we have examples of this that they can practice on the website. So, Simon's best friend is away from school. What's the worry thought? Is it thinking I'm going to have no one to sit with at lunch? Or is the worry thought him thinking I can go and sit with some of my other friends? So this kind of building of cognitive flexibility, being able to identify that not all my thoughts might be completely true, and that there can be sort of worry thoughts and there can be more calm thoughts as well. The last stage of this, and at every stage, we then kind of do the self-application. So, for example, if a young person was having some worries about things or some unhelpful thinking patterns, then we just apply identifying the worry thoughts or the unhelpful thoughts. Then in the last stage, we sort of have this activity around detective thinking. So this is where we encourage children to be a detective, and this is helping them challenge thoughts, essentially. So we've moved from identifying to actually sort of trying to challenge and change thoughts. We use a bit of a catchphrase, stop and think. So, Frank wants to ask the teacher a question in class, but Frank thinks if he asks the question, the other kids might laugh at him. Frank should stop and think. So the stop and think is a common catchphrase we use throughout. And we think about, what else could happen? What else could it be based on past scenarios? What's a more helpful way of me thinking in this situation? So we're trying to now move from just identifying an unhelpful thought pattern to actually coming up with a more helpful one based on reality and based off of experiences or what's more likely to be true. And then, of course, we have the module that's about the more kind of practical behavioural changes. So this is in the context of the anxiety that we've looked at targeting here. It might be sort of facing fears. So we develop a hierarchy or a plan with a young person about how they can move step by step to overcoming a fear. So, for example, in this scenario that we've used, we talk about Brave Ben, and Brave Ben is afraid of heights, but his whole class are going on this excursion to climb the Harbour Bridge in Sydney, and he really wants to go, but he's scared of heights. So it's all about how he overcomes this fear of heights. So he starts by going on a low bridge, then, he climbs a mountain with his dad, he goes on a hiking trip, and then he sort of goes step by step. Again, this catchphrase here is the step by step. And eventually gets to go on the excursion with his friends. So there's a video. I won't play it, but again, this is all linked in the program and on the website, etc. This is typically one of the things that children seem to remember a lot and reference a lot, the story of Brave Ben. This is not necessarily an activity in and of itself, this video. Some of the other videos we have, like the progressive muscle relaxation, the goal is to practice along with them. This video really is designed to provide psychoeducation to kids and to families, to explain why Doing the things we don't want to do or the things that we're scared of doing can actually be quite good for us and can help us achieve our goals. This can be, I find, quite a hard concept to sometimes explain, particularly to kids with intellectual disabilities. Why is it actually good for you to do the things that make you anxious or the things that feel hard? But this video was designed to help explain that through the story of Brave Ben. So what we also ask kids to do is just sort of provide a rating before and after they do a step on their own hierarchy or ladder. So it's this idea of how worried did you feel before you did that step of going on the mountain hike, and then how worried did you feel after you did it? The view being that via exposure to the things that make us anxious or uncomfortable, we're able to actually reduce our level of anxiety over time. So if I'm worried about something and I do it, I kind of prove to myself of like, oh, actually, it's probably not as bad as I assumed it was going to be. And I have this, what we would refer to as some sort of like corrective experience by being able to do it. So if I come back to the adaptations according to those different cognitive domains, we really try to include a whole range of adaptations when thinking about the best ways we can work with young kids with intellectual disabilities, and looking at, when we do this work, again, whether it's been in classrooms or whether it's been in one-on-one sessions, we're always looking at having breaks as needed. You'll see that particularly with the cognitive stuff, we try to break it down into the smallest components possible. So it's like the first part of being able to do anything with thoughts is being able to actually identify that I'm having a thought and that thoughts exist, and doing a lot of work around that before we then build on that and be able to think about, oh, I can have thoughts, and sometimes they're true and helpful, and sometimes they're not true or they're not helpful, and then building on that to be able to challenge them. So it's really about dividing this concept of thinking into the smallest tasks possible, and building upon those. We also really try to incorporate technology through the websites and the videos to be able to facilitate engagement. One of the things we heard from when we did those like confidence surveys for people working with young people with intellectual disabilities is them saying, they constantly felt like they had to find and come up with resources. And so this was partly to build confidence, but also partly to kind of reduce the administrative, burden that might come with having to kind of come up with ways to teach these skills. We also had parents involved in a lot of the sessions when we did them one-on-one. When we did the classroom sessions, we haven't had parents involved other than being, as in they haven't been in the classroom, but we do sort of send them a summary at the end of each session to let them know, in the class today we covered this topic. This might be good to sort of cover with the young person at home. We have a lot of repetition of the different skills and practices. We have that text-to-speech function. And also when they do the activities on the website, they will get immediate feedback as to whether they've got something right or wrong. Some of the kind of feedback that we had from our clientele, from both parents and carers and the young people, really liking the kind of squeeze and relax, something that has a movement attached to it, as well as the kind of catchphrases. Feeling like what the parents were talking about, feeling like their young child can better express themselves and actually communicate when they are struggling with something. So that sense of emotional literacy building. But this one I quite liked. I just include this little quote that we got from one of the parents. A young child was sort of quite afraid of storms and rain and thunderstorms. And so one night when it was storming, the girl didn't get out of bed. She stayed in bed. She started doing the balloon breathing and the squeeze and the relax. And then she started saying the rain is for the flowers so that the flowers can grow. So this idea of having internalized the cognitive restructuring and being like, identifying thought processes, but finding more helpful and healthy ways to think about things. So this was a nice example I just like to include of what one of the parents shared with us. What I would also like to do is kind of point you in the direction of other resources that I found really helpful when working with young people with intellectual disabilities. There is something developed that's called the Westmead Feelings Program. This is specifically for children who have a diagnosis of autism, though they have a program for and they provide sort of teacher and parent training in this, but they have one that's specific for autism and then another that's specific for autism with an intellectual disability. So there's two versions of that. It's a great resource. This is, I'll just go back to that. This program is really designed around building emotional awareness and understanding, but also kind of more of those social skills as well. But it's like emotional, social focused program. There is also a Stepping Stones resources. So Stepping Stones is work that can be really effectively done with carers and parents to help their child manage any kind of mental health concerns. Again, maybe from that more early intervention framework, but any sort of disability is also included with this. And then finally, there's the Department of Developmental Disability and Neuropsychiatry, which is commonly referred to as 3DN. They're through the University of New South Wales, and they have a website that I've just put a screenshot there of, which has a whole heap of free resources. So there's resources for professionals who are working with people with intellectual disabilities. There's a lot of their research and publications shared on there. But also resources for people who have lived experience of an intellectual disability and mental health concern. So their site has some great tools and resources that I think are worth looking into and exploring the ways they can be useful for the work that you're doing. So on that note, I'm going to wrap up the presentation. Thank you for listening. And as I said, if you're ever looking for resources online, everything relating to our program should be freely available. If you can't find it, contact me. And I'm more than happy to send stuff around as needed. But otherwise, I'd be more than happy to take some questions if there are any on this topic.
Always questions, Anastasia, always questions. Thank you so much. That was very, very insightful and very practical. A lot of comments here about how practical and useful it was. Now, let's quickly shut down the slides. Everybody's got copies of these in the portal already available as we speak. Now, for those of you that are logged in with us right now, use the chat function or the Q&A functions to submit your questions. We're going to try to cover as many as possible in the next 30 minutes or so. And I've got some already here, Anastasia, and I'm going to start going through them. So the first one is, when a student's intellectual disability impacts emotional understanding, what's the single most powerful mindset shift a teacher can make to support them better?
Oh, the single most effective mindset shift.
Yeah. This might be an opinion, not an evidence-based response, but, your opinion is valued.
Oh, gosh. I think when it comes to mindset shift, I think this understanding, building the understanding that, things that we think and tell ourselves can be untrue. Our brain and our mind sort of tells us all sorts of words, and those words come together in sentences or pictures or memories, but not everything we tell ourselves is true. And if we can teach a young person this, as it applies to their mental health, if we can teach a young person this idea that just because I see some kids laughing at me, it doesn't mean, just because I see some kids laughing, it doesn't mean they're laughing at me, just because that's what my brain tells me. Or just because I see a dog doesn't mean I automatically need to think it's going to bite me. Not everything my brain tells me is true. Not all the self-criticism that my brain also tells me is true. Because while I've talked a bit about high levels of anxiety and worry, because this is often what we see in young kids with intellectual disabilities. The second kind of common thing we often see is internalized self-criticism, when they feel different to other children, or when they feel like, they're not learning at the same rate as other kids are. They're not processing information as quickly as other children are in the classroom, etc. And they start to internalize some quite negative beliefs about themselves. So keeping these two things in mind about sort of self-criticism and anxiety, being able to shift children to understand that they don't need to believe everything their brain tells them, can be a really powerful shift for them.
Thank you very much. What's one common myth teachers hold about children with intellectual disabilities and their emotional lives that research flatly disproves?
The big one here is about children being less impacted by adverse life experiences, difficult challenges in life, etc., because they have limited cognitive capacity. You know, it was kind of thought that if there's reduced cognitive capacity, there's reduced ability to understand how bad things might be or to process how bad things like traumas might be, and therefore that they won't be impacted as much. This was kind of a long-held belief for quite a period of time, but the research has quite clearly shown that this is not actually the case. And in fact, the opposite is true, where because of challenges with cognitive abilities and cognitive processing, we actually often see that these traumas or these adverse life experiences impact people with intellectual disabilities more greatly than those who don't have the intellectual disability. So it's actually the opposite to what was historically thought to be true.
Thank you. If you could wave a hand and have every teacher master one psychological concept to help these students, what would it be?
Ooh, I want to say emotion regulation as a very broad kind of umbrella. I know there's a lot within that, but you know, often I think having a good grasp and understanding for anyone of emotion regulation strategies and skills is going to help a young person in every area of their life, whether it be trying to make friends, whether it be trying to sit down and do some homework, whether it be trying to get a job later on in life, you know, whatever the kind of challenge is that a person might be presented with at some point in their life. If they have sound emotion regulation skills and strategies underneath their belt, then this is going to help them navigate those challenges with a greater degree of success, but also be able to navigate those challenges when maybe they don't turn out as successfully as they might have hoped, or they don't necessarily get the job, or they don't necessarily make the friends. You know, having those emotion regulation skills just going to equip them for kind of all outcomes in life.
Nice. And for teachers that are interested in this area of emotion regulation, I want to have a look at the Ruler program by Dr. Mark Brackett from Yale. He's quite good, and he's developed a program that I think it's used by over 5,000 schools in the United States alone. But we actually hosted a webinar with him in 2 days on that note to think things timely. So definitely recommend. And he's also got a new book out, which is all about emotion regulation. Next question. How can teachers adapt emotion regulation tools like stop and breathe techniques for students who may struggle with abstract instructions?
This is where breaking down the skills into the smallest task possible really comes in handy. We worked with a number of children who really struggled with abstract thinking, but also kind of had a number of additional challenges. You know, they had cerebral palsy, or they were in wheelchairs, or they had vision impairments, and they had the kind of intellectual impairments as well. So really a kind of range of challenges that they were facing. And what we found to be the most effective thing was really break things down into the smallest component. This is something that I think for teachers is a skill in and of itself, because if we're working with a child of a certain age, we might kind of assume a certain level of knowledge or a certain level of understanding, but really starting from the micro unit of that task and building up from there and going slow, really sort of consolidating that first step, making it as practical as possible, using those sort of we have I refer to them as catchphrases throughout the program, but really they're just sort of phrases that we find quite easy for kids to understand and remember, like stop and think, or go step by step, or squeeze and relax. You know, we've done this intentionally to be sort of practical reminders that can ground them in being able to do an activity. So breaking it down, going slow, and using those sort of short, simple, but memorable phrases.
This might be a silly question, but do you find, in your experience anyway, have you seen this happen where teachers kind of do exactly what you said, but then they're going to work with another student who has different needs or is at a different level of whatever spectrum of assistance they need? And because teachers are busy, and you always kind of, in a way, you're trying to get shortcuts wherever you can, that it's very easy for them to kind of assume that student, the thing that worked for one student might work for the other.
Yeah.
And if that's the case, what's a good way for teachers to always keep in mind, not fall on that trap of assuming?
Yes, this is such a good question, because to answer it simply, yes, we do see this, and by no fault of anyone's, right? As you say, like, teachers are busy, and if one strategy works for one kid, we would like to hope it works for the next as well. But I think this is where maybe part of this is not always the responsibility of the teachers, and maybe this is where someone like a school counsellor or a psychologist who's done the assessment of the intellectual disability, who has that full neuropsychological profile, who understands that kid's processing speed, their working memory, their attentional difficulties, like whoever's done the assessment and has the numbers and the data, that's really a job for them to be able to come up with a list of recommended strategies and ways to help engage this young person and work with them. And this is where I would be suggesting that teachers try to access that information from whoever's done the neuropsychological assessment, so that they don't feel like they need to be coming up with those strategies themselves, but rather have those recommended based on the profile and the very kind of unique profile of that individual child.
Thank you very much. What does a 5-minute emotional literacy routine look like for a mixed ability classroom?
Ooh, mixed ability classroom. I would say, in even less than 5 minutes. One of my favorite tools and resources to use when building emotional literacy is those emotion wheels. So you can find these online very easily, which is just like a wheel of all the different kind of emotions that we can experience, from the kind of more obvious ones like happy, sad, angry, to more nuanced ones like excited, nervous, anticipation, etc. So really sort of breaking down into the nuances of emotional states, and simply asking kind of children or young people to identify how they might feel in this moment, or how they might have felt over the weekend at a certain point in time. Pick a point in time, get kids to reflect on their emotional states. But also, the part of this that I really like is that it's quite interesting when someone is experiencing two seemingly opposite or conflicting emotional states at the same time. So, for example, I can identify on an emotion wheel that I feel quite nervous, but I also might feel excited. And these sort of seem like opposites, but they can both coexist. So using emotion wheels and kind of work around identifying emotions to not just identify individual emotions, but understand and learn about how competing emotional states can coexist within us at any point in time.
Thank you very much. When a student has an emotional outburst, what are the first 10 seconds teachers should focus on? What are the first 10 seconds teachers should focus on, and what should they avoid doing?
Ooh. Avoid assuming and focus on connecting. I think a lot of the research tells us, and from my kind of clinical experience with young kids, is that if we can engage a young person on a kind of human-to-human level initially, whether that be with kind of empathy, validation, understanding, just kind of emotional attunement to that young child, trying to attune to understanding what they're feeling and perhaps why, that's going to be the most effective thing to help any emotion regulation strategy that we then implement be more effective. If we just come in with the emotion regulation strategies, but without that kind of emotional attunement with the young person, I would say that there's less of a chance that the strategy we suggest is going to be as effective as if we've kind of connected with them first. Because from that point on, it could be doing some box breathing, balloon breathing, progressive muscle relaxation, using cold packs, ice packs, whatever it might be. It's a whole range of emotion regulation strategies. But unless we've had that moment of emotional attunement with the young child, the strategies might not land as effectively.
What would that look like in practice? So a child is screaming, and I guess the teacher comes along and sort of warmly asks, I can see you're frustrated, something like that, or?
Yes, yep. It could be depending on the child, getting down to their level, looking at them, like crouching down next to them, either face to face or next to, depending on the child. I might be asking the young child to look at me. If it's a child with perhaps autism or a child who doesn't do so well with eye contact, I wouldn't necessarily go down that path. But if they are comfortable with that, ask them to look at me, ask them to, I'd be saying their name. I'd be asking them to just sort of take a breath. And as you said, saying, I can see that you're upset. I can see something's really made you feel really mad or really angry or upset. Tell me what you're feeling. Tell me what's going on. Help me understand. So it'd be the understanding piece first. And then once that's been established, providing some suggestions. How about we go and go to the bathroom and we wash your face? Or how about we step outside and we do some of our balloon breathing together? Or whatever strategies have already been established with that young child.
Thank you. Can you share a simple way to visually represent thoughts, feelings, and actions for students with limited verbal skills?
Yeah, I think when I typically write the 3 words, but sometimes, I've actually had children kind of do this with me where they'll sort of suggest different visual images. So when it comes to thoughts, I'm always thinking brain. So I'll try and draw a sort of best version I can of like a brain to signify this is where our thinking happens. Sometimes when we talk about like emotions, I'll draw either an outline of a body or sometimes even kind of a heart, although heart is hit and miss. We don't want all emotions to be attached to the heart. So sometimes I'll just draw an outline of the body. And then when it comes to do, I might sort of show someone doing something like running, depending on how good your stick figure drawing might be. Or it might be sort of a pair of hands to show like, we often do things with our hands. But this is where I would probably lean away from making the assumption that I know what's going to be a good visual representation and maybe asking the young person I'm working with, what's a good picture we could come up with to signify doing things? What's a good picture we could come up with to signify emotions and feelings, and sort of just see what symbol or image they can suggest to help represent that idea.
Thank you. That's very useful. What's an underrated sensory or environmental adjustment that often makes a big difference in emotional regulation for these students?
My number one big one is always cold. Anything cold. If you can get a young person to do it, or even an adult to do it sometimes. But one of the things I find most, we can either kind of go down a more self-soothing pathway, which is things that sort of calm the nervous system, or we can go down a pathway where we provide more intense sensory responses. So this is where the cold can come in and be really effective. So what I always recommend is keeping ice packs on hand in a freezer, if you can have a freezer nearby, depending on where your classroom is. But ice packs can help activate the deep dive reflex. So what this essentially means is that we try to replicate, if you were to be feeling very overwhelmed with emotions and you were to then jump into a swimming pool filled with water, your heart rate would lower, your blood pressure would change physiologically. On a physical level, your body changes and you physically sort of regulate your nervous system. We try to replicate this using the cold. And so I would get ice packs, and I would encourage a young person to put the ice packs over their forehead and around the kind of eyes. It's this like top half of the face that we want to activate with the cold to activate the deep dive reflex. And if they can also do it, sit in a chair, lean over so that your like face is facing the floor, ice packs on your face, and hold your breath for about 30 seconds or however long as possible. This is the combination of these things mimics that idea of jumping into the swimming pool of water, because you hold your breath when you're underwater as well. So cold is very effective. Holding ice cubes in the hands can also be effective. If someone's at home, I'll recommend they have a cool or a cold shower. The cold is just very good for helping us re-regulate, if people can do the intense sensory stuff. If not, then we go down more of a self-soothing pathway. So using the senses to sort of help calm and regulate the nervous system. So calming, textures like velvets or touching sequins. It might be calming smells and incense and candles and, more like kind of plushy toys that they can sort of squeeze, etc. Anything on a sensory level that can be calming.
Thank you very much, Anastasia. That was very interesting. I never heard of that before. What are the most effective ways for teachers to communicate emotional or behavioral patterns to parents without triggering defensiveness? Good luck with that.
I think when it comes to the defensiveness piece, like I often, as I do the presentation, you would have heard me use the word skills a lot of the time. I really lean into language around skill use and upskilling, and these kind of being skills and strategies that everyone can benefit from. And doing that in order to kind of take away any judgment or self-blame or shame that kids or adults should know these things, or they should have been taught these things, or they should have been modeled these things by parents, etc. Sort of taking that layer of potential judgment away, and really kind of talking about this as a skill in the same way that we would teach the skill of maths or the skill of, reading or any kind of skill in the classroom. We also teach skills about managing emotions, because we all have emotions and we all need to learn ways to manage those emotional experiences. And so we teach a series of skills to kids to be able to understand what to do when they have those feelings, whether they be big feelings or whether they be small feelings. And I think if you can come at it from quite a sort of like practical, matter of fact, this is almost just like a part of the curriculum, like we'd teach anything else, that can take away the layer of judgment a parent might feel, and any potential kind of defensiveness they might then react with.
That's a good point. What about your thoughts on how teachers can help align home and school strategies when parents may have different expectations or level of understanding?
I think this is not an uncommon experience from what I've heard from teachers that I've worked with, where perhaps the expectations for the classroom and how a young person is expected to sort of operate in the classroom might be quite different to the expectations for home. So I think, this is a challenge that will present itself throughout life, right? That in different contexts, there are different expectations for how we present ourselves. And so sometimes I think that rather than trying to align those expectations, it can be sometimes more useful to help teach kids that different environments come with different expectations. And, being at work, being at school, being out in the playground with our friends, being at home with our family, there's different kind of ways in which we are expected to operate in these environments, and that this is a skill to learn in and of itself, to understand what is expected of me in this environment, and that might change from context to context.
Thank you. If parents are overwhelmed, what's one small first step you would suggest they take to support their child's emotional development?
Oh, I'd say the first step is support yourself. While I was doing a lot of my research in this area, I had a colleague who was looking at helping parents and the level of stress that parents had who had children with not just intellectual disabilities, but any kind of neurodevelopmental disorder. And of course, what we see is these parents have very high levels of stress. They're constantly sort of taking children to different appointments. It's to the occupational therapist, and then the speech therapist and the psychologist, and then after school activities and all the rest of it. And so they're often very burnt out being in that carer role and that parenting role. So I would say that part of the first step of managing the overwhelm of parenting a child who has additional needs is being able to sort of give yourself what you need in those moments. If you are feeling overwhelmed, rather than thinking about how do I better manage my child or implement strategies with my child, maybe turning it to, what do I need right now? I'm a person with emotional needs, and maybe those needs are not always being met, and how can I sort of turn some of that focus and attention towards myself rather than just towards my child.
Thank you. What role does peer modeling play in helping these children build emotional awareness, and how can teachers encourage it safely?
I think this is where running the Fearless Me program as a group was really nice to be a part of and observe. When we did this in schools, there would, because of the nature of the classrooms, there was always sort of a mix in terms of the children's level of disability and cognitive capacity. So we always had some children who were more willing to just participate in lots of things by nature of their personality and who they were, but also children who were perhaps a little more competent with some of the skills and could pick those up a little bit faster as well. And so I think when used effectively, this kind of peer modelling can really help facilitate the learning of some of the children who might need a bit of extra time or a bit of extra modelling from others to be able to implement the skills. And we heard one of the nice stories we heard was the children after school were catching, these were senior school students, so they were probably between the ages of 13 to 18, and they were catching the train home after school, and suddenly all the trains had been cancelled, and we'd had one of the group sessions that day, and so they collectively got together and they were like, right, okay, we're not going to panic, we're not going to stress, let's do our breathing. So they then, like, I think there was about 4 or 5 of them, they all did their breathing together. And then they were like, okay, the sort of detective thinking, stop and think, what else can we do? Okay, do we need to call someone's mum or dad and let them know, like, you know, do we need to ask someone when the next train is coming? So they like kind of worked through the problem solving skills and then came the next time and told us about how they used those skills. And I think it was a really lovely example where, you know, I'm sure there might have been 1 or 2 of those young people who were kind of leading those conversations, but was nice for the kind of the small group of young people to experience that together and see in real time in their day-to-day lives how these skills can be helpful for them.
So you're telling me they didn't get together and decide to go to the shopping mall?
Apparently not. They did something very responsible.
Yeah, that is very impressive. What are some quick evidence-based interventions teachers can use to prevent emotional escalation before it starts?
This is where I would say that that emotional literacy about being able to identify emotions is so important. You know, when we think about emotion regulation, we often think through the lens of how do I manage emotions? But really, the first step of emotion regulation is being able to identify emotional states and experiences. If we can teach a young person to identify their own emotional experiences, it means that before they escalate, where we perhaps as a teacher or someone can see that emotional state because it's got so big and so loud and so overwhelming, if we can teach a young person to identify that emotional state within them from when it starts to feel like it's escalating and creeping up, that's going to provide them with such a valuable skill throughout their life, because it's when they're in that you know, I often think of a traffic light system. When we're in red zone, that's when we're in crisis mode, but that's also when prefrontal cortex is offline and we're acting in a very emotional way. If we can teach children to identify their emotions in green zone, or when we're getting a bit wobbly in the kind of orange-yellow zone, they still have the capacity to be able to communicate effectively when their brain is in those zones. So this is going to be when they're best able to communicate and perhaps ask for help with emotion management, or be able to kind of do something themselves to regulate those emotions.
Thank you, Anastasia. Next question. How can schools design policies or routines that naturally build emotional literacy for students with intellectual disabilities?
You're asking me to change the systems.
I expect you to do it immediately after this webinar finishes, but for now you just need to answer the question.
Yes. The reason I include in the presentation that I went through that roadmap that we have for health inequalities and health outcomes is because I think it really speaks to the need for prevention. At least that's one of the key things that I take away from it. And so I think when we're thinking on a school-based level, we really see the opportunity for prevention to be integrated into the classroom and early intervention to be integrated into the classroom experience. I think for children who do or don't have intellectual disabilities, this is the case. And when we think about being able to support kids with an intellectual disability in these spaces, it really comes from having structures which are inclusive to the learning needs of all kids. when I say that, I really mean kind of learning needs as they apply to mental health and well-being. So having space and tolerance for the fact that there will be different emotional reactions and responses from different kids, depending on their learning abilities, but also their emotional capacity, and being able to kind of have, as I showed in that framework, stepped care models that say, okay, if I'm working with a young child in the classroom who has really sound mental health versus a young child who's highly at risk of developing mental health problems, there might be different approaches to those young kids depending on where they fit on that model of stepped care needs, because not each young person is going to come with the same background, history, or level of vulnerability as the next one. So being able to provide the right support for the right person at the right time.
Thank you. Follow-up question to that one. If you had 5 minutes with a school principal, what would you tell them to prioritize in supporting teachers working with students with intellectual disabilities?
Oh, I would tell them to prioritize building children's self-concept. And I guess what I mean by that is I'm coming back to this notion of internalized self-criticism and anxiety that develops often by kids feeling like they're on the outside or like they aren't learning as well as the other kids, etc. And if we can kind of flip the frame and focus on building an individual child's sense of self-concept, their self-confidence, their competence, one of the core emotional needs that we all have is the need for autonomy and independence and to feel competent in life. And if we have this, we generally feel more confident to be able to deal with what life throws at us. It's not to say that we always have the answers, but we feel like we have the capacity to figure it out. I would say that this is a skill that will help children navigate whatever comes their way in life. And so I would suggest that the principal and the teachers help focus on building these as they go through all activities in the classroom.
Good point, good point. Now to teachers, how can teachers protect their own emotional bandwidth while doing this deeply relational work every day?
Oh gosh, that's a whole webinar in itself, Pedro. Teachers' self-care and preventing burnout.
We've got 5 minutes to answer that question, so take your time. Just point out to the top 2 or 3 strategies, perhaps.
Yes. I was actually doing some research into the literature, not my own research, but reading the literature around the concept of empathy. And I learned something that I wasn't as familiar with, and it was kind of the different ways in which we can experience empathy as a construct, and that empathy is divided into affective empathy and cognitive empathy. So affective empathy is this idea that if I'm sitting with someone who's struggling, I feel what they feel. If I'm sitting with someone who's sad, I also kind of feel that sadness as well. That's the affective empathy. A more cognitive empathy is I have the ability to understand what you're going through, but I don't necessarily feel it along with you. And the literature sort of suggesting that affective empathy is not as helpful for us. It's actually not as helpful for us to feel the emotions someone else is as it is for us to cognitively understand their emotional experience and kind of want to help them through that. So in talking about kind of potential teacher self-care, teacher burnout, etc., I would say other than the very practical things about make sure you have time for yourself and make sure you do your routines and go for walks, etc., which is stuff we've all heard before, I would encourage teachers to reflect on, do I get stuck in affective empathy? And what do I need to do to shift that to be more of a cognitive empathy, where I still have a desire to help and I still have an emotional understanding of, this young kid's big feelings, but I don't feel like I necessarily feel it myself, because that will protect against sort of burnout in the long run.
Interesting. Is there any research on the types of, personality types, if you want to call it that are more prone to the affective empathy trap? We shall call it that.
Yes. There were, well, it wasn't personality types, but the literature did look into different mental health presentations. And so it sort of said that people with I think it was people with schizophrenia and narcissism have lower affective empathy, and people with autism and borderline personality disorder have lower cognitive empathy. So there's definitely differences in terms of kind of in mental health presentations, but I'm not actually sure about different personality types.
There you go, everyone. Research for you to do tonight. You can start on ChatGPT and move from there. Make sure you check your references. Anastasia, it's been a total pleasure. Very interesting insights. Thanks for answering all the curveballs I threw at you. And we got a minute and a half to wrap up the session. I just wanted to give you an opportunity just to say some final words. It can be, some final recommendations, some words of inspiration, recommended playlists from piano concerto.
My big takeaway in this area is the confidence. Often we work with teachers, clinicians, counselors, etc., who haven't done much work with kids with intellectual disabilities and almost feel like scared to approach that because they don't feel like they have the skills. And what I'm often saying is it's the same skills, you're just breaking them down and delivering them differently. So all the core knowledge that you have is totally applicable. It's more just how you break it down and package it up and deliver it to kids with intellectual disabilities. That's going to be the difference. So my last message would be to encourage people who maybe haven't done much work in this space to lean into doing it. It's very rewarding work. Kids are great. Kids with intellectual disabilities can be a whole bag of fun to work with. So I encourage you to use the skills you have and look at how you can apply those for the unique needs of kids with intellectual disabilities.
Thank you so much, Anastasia. That's the final point there. The greater the challenge, the greater the reward. And yeah, it's the same applies to clinical mental health. There's a lot of, mental health presentations that can be quite complex. One of them is personality disorders with addictions. We did a recent masterclass on that, but at the same time, when you are working with those individuals, you manage to help them, it can be extremely rewarding. So, just got to keep things in balance and try not to burn yourself out by doing too much. All right, so for those of you that are live with us right now, the slides are already available via the event portal, and given about 5 to 10 minutes, you will also get access to the handout plus the certificates through the evaluation survey. Anastasia, once again, thank you so much for joining us. Look forward to connecting with you again for whatever next crazy thing we decide to do together. But in the meantime, have a great week, and thank you so much for coming.
Thank you. Thank you, everyone, for listening, and thanks, Pedro, for having me.
Goodbye.